First of all, I'm sure that's somebody else's profile. I just wanted to start by saying my one key takeaway is this chocolate frog. Give me the chocolate frog first. The pressure's off. Oops. Back. Basically, today what I'd like to do is go through and explain some of the new technology that's coming out and some of the emerging trends that are coming out and how that will affect some of the cancer spaces we design. I believe some of these technologies are really going to help us to address some of the workforce shortages and just some of the issues that we have with talent out in our regional areas. And the way I'm going to go about this is I'm going to simulate a cancer patient's journey from sort of when they get the symptoms to going through diagnostics and then from diagnostics into treatment. So as we know, we all know about genomics and DNA and stuff like that. We know that even before we're born, there's a good chance that we can look at our DNA and understand how we would potentially pass away from what's already pre-coded in our body if we live naturally. So what's interesting, though, is we're born, we go through life, we pay lots and lots of taxes, and then we finally pass away. But somewhere along the line, we get symptoms. And before those symptoms, we were healthy, but now we have symptoms. So once we get the symptoms, what do? Well, we go to a local GP. The GP uses a series of diagnostic tools, imaging, stuff like that, pathology, whatever else, to ultimately come up with a diagnosis. And once we get a diagnosis, what happens? We go to a specialist. And that specialist, in this case, we're following a cancer patient, that specialist has certain tools up their sleeve, and those tools are radiation oncology. They've got radiation therapy units, linear accelerators, chemotherapy, those sort of things. That's the traditional way. What if we can use some of those same traditional treatments and that equipment to start looking at our bodies and looking at the population earlier, sooner, before we get symptoms, with ultimate goal of really just trying to improve life and potentially extend their life. Now, we're not there yet, but this is where this is all going. We talked about AI and we talked about lots of other stuff, but this is definitely where we're heading. So there's lots of emerging trends in the diagnostic space and the treatment space. I'm not going to go through all of those trends. Those trends have got impacts. And some of the trends that I'll talk about today, we'll talk about what AI does. We'll talk about something called theranostics, molecular imaging, and then we'll sort of dive into theaters a bit. But we're already seeing health respond to these trends. We see that there's Medicare reimbursements now that are being released. We're building specialist centers like the mRNA Center, the Viral Vector Center, just over in Melbourne. They've got the International Medical Robotic Academy. We're building specialized centers as a response to these trends. But the other thing that's coming out is we're also seeing that the equipment suppliers also have to evolve their technology to these trends. And as such, we've got to adapt our design to these trends. So I'm going to start with something really simple. I'm going to start in X-ray. This is a cath lab. There's nothing really too special about this cath lab except it's got AI embedded into it. So what this cath lab can do that's a little bit different than most cath labs is it has the ability to acquire images using very, very low energy X-ray called fluoroscopy and get as good or even better image quality than high energy X-ray techniques such as Sydney, if you guys are familiar with that. Now, it does bring some benefits. It reduces the staff dose, it reduces the dose to the patient, and it's got some other benefits as well. The X-ray tube's not getting hammered is hard, so what that means is that tube lasts longer, so you have advantages with whole-of-life costs and stuff like that. But it doesn't really impact design. The footprint of this is going to look like the footprint of anything. But I'm starting with this because it's a good indication of how AI is now starting to affect image quality. The reality is this gives us really good image quality, and no matter how good the surgeons are or no matter how good the radiologists are, if we can't see things, the best radiologist in the world can't diagnose it. And this is where this is going, so it is going to have an impact. This is molecular imaging, PET CT, SPECT CT. What you're seeing here is you're seeing the typical way a patient is acquired. We acquire in a one little zone on the patient. We take an image and we slowly stack those images. And this usually takes about 30 minutes. And that's, I'll show you something else in a second. Yeah, we'll go from there. So what's really unique about molecular imaging is it's the only modality that allows us to look and see what living tissues are doing, what's happening at a cellular level. Nothing else does that. And to explain that, it's a really stupid example, but I'm going to use it anyway. If I take an x-ray of a snake that's alive, and an x-ray of a dead snake, and you look at both x-rays, they look the same, because x-rays don't care if the snake is alive or dead. But if I do a nuclear medicine study of a live snake, and I do a nuclear medicine study of a dead snake, I get a beautiful image of a snake from the live snake, but this I see nothing, because there's no living tissue. So simply what we do is we use a radiopharmaceutical that goes through the body and looks at living tissue. But again, we can only look at one part of the body at a time. So if we're imaging the head, we don't know what's going on with the heart. If we're imaging the heart, we don't know what's going on with the lungs. So what if we did something crazy, like built a big, giant PET CT, that would look at the whole body at once? First of all, it's too expensive to do all the time, but we do have some of these currently available. So what's this do? So it's an increase in hardware. It's obviously got an increase in design. It weighs more and all those other things. But those things we can cope with. But let's see what else it will do. So what it allows us to do is inject a radioactive isotope, and we can trace that all the way through the body, and we can see every single organ as it responds to that. So we get to track this. What that allows us to do is that allows us to map the response of all the different organs, but not just the organ, it also allows us to map the response of all the different organs with respect to the other organs. This is the first time ever this has happened. The first time anyone's been able to see this. This is actually groundbreaking. We got a few of these. There's going to be about 7 of them, I think, installed between Australia and New Zealand in the next year. Now, cost prohibitive from a design perspective for most sites. You need specialist people and all those things, so we'll get into that. But just remember, we can map this function out. So just for fun, let's take a healthy patient. Is there a laser on this? No. Okay, we take a healthy patient, and we just image the same way we did before in this whole body scanner, and you can see a perfect image up in the top right of the brain. You can see the heart, and you can see the legs. But because we're a little bit mean and we're a little bit sick, let's get this patient off the bed and let's go plunge them in an ice pool and see what happens. Ha-ha! We plunge this patient into an ice pool, and what you see is a lot of uptake in the brain. The brain's going, whoa, what happened? You can see that uptake in the brain. You can also see the legs going, wow, I'm freezing cold. Please, Mr. Heart, send me some more oxygen. And you can see all 3 of those organs, the way they respond at once. Clinically, does this mean anything? No. But what I want to do is demonstrate that what we're able to do is see this now. And again, the information that we get from this allows us to set baselines. Once we have those baselines set, if we see those baselines shift, it means something's occurred, something sinister, and in this case, we're looking at cancer. So obviously there could be some cancer issues that happen here. So we'll park the hardware for a second, and we're going to talk about an emerging trend. So this is called theranostics, and theranostics is simply doing diagnostic imaging and patient therapy in the same place on the same machine. Simple as that. Theranostics. We don't really get too creative, do we? But simply what this is if you look at the top left, you see the image up there. We take a small, really safe, low-dose radiation, and we try to tag it to cancer. And if we inject this, pretend they're 2 different patients, but they got the exact same cancer. If we inject this radiation into them, and if it sticks to the cancer, as you see on the right, all those black spots, then we know that we can identify the cancer. We know that we got something that will hunt down those cancer cells and find it. All we do is find it. Now, that's the diagnostic part. If you look at the left side, it didn't happen. So it didn't stick to the cancer cells. So that patient there, even though they got the exact same cancer, that patient cannot use theranostics, so they go the traditional, conventional treatment. Where's this going? I can see this look. Beautiful. That's what I wanted. So if we can tag the cancer, what we can then do is take what we call a theranostic dose. We just put a little bit more radiation into that dose that hunts down and kills the cancer because we know that we can identify those cells and kill it. What's that look like? So as you can see on the left, you see a patient that has lots of cancer, unfortunately. The little green box is we give a theranostic dose. The center box, as you can see, there's less black spots, less sinister tissue. And then you see the right box, and you see the cancer clearing up. It's absolutely beautiful. The side effects to this are almost nothing compared to chemotherapy and stuff like that. If you look to the right, what you see here is you see a whole bunch of other radiopharmaceuticals that are being developed to target organs. So this is getting really into personalized medicine. And again, what have we done? We used a diagnostic space to treat a patient. Again, that's fundamentally different than the way we approach things. So now we got to start looking at models of care. What's this look like for design? For design, we need that space, top left, to be able to inject the theranostic dose. It is radioactive. And we also need that consult room. We need that space. And these are some ugly images, sorry. The bottom left, we need the equipment in a hot lab that allows us to do this. We need the synthesis machine. I'm not here to dive into technology, but we need space in the hot lab, but we need the chemistry space. On the right, we need specialized equipment. And this is becoming such a trend around the world, and it's in such demand. We've got centers like the top right, which is in Munich. They've built a center just to do this. Rod Hicks, from you guys down in Victoria, worked at Peter Mac. He's actually set up a center in Melbourne just like that, just to do this, because there's that much demand for it. What's this look like for design? So if I ask the question, is this PET layout, which is a typical PET layout, and I'm not going to dive down and try to teach you guys PET, is this optimized for theranostics? And this is where it starts to get into the critical architectural space, right? Well, when I look at this design, I notice that there's no place to inject patients. There's no little secure spot. There's no consult rooms. The hot lab is a standard size hot lab, so that's not big enough for that specialized equipment. And there's no spec CT, which it's definitely a mistake not to put a spec CT in with a PET unit. So this site is not theranostic optimized. We missed an opportunity here. And this is so good for patients, right? So all of that design, that bit, if we get in early enough, we can sort that out. We can figure out the spatial requirements and all that. We're working with all HFG. We're talking about this stuff now with the different parts of the team. But what's really important here is the effect it has elsewhere. It's the change management part. It's that the staff flow, the patient flow, it's different now. It's the training, the staff responsibilities now. So they're used to just injecting patients, scanning them. Now they're injecting patients, scanning them, and then treating them. How does that work? So we've got those change management things that we really got to think of early, and we really need to be involved early. So I've got one project that actually is doing something like this, so we're giving some of this advice right now. It also has an impact on the other departments, so oncology departments and stuff like that. So we've really got to start thinking that through. So we've gone from imaging to something between imaging and therapy to treatment. So a linear accelerator, it just uses a really high beam of radiation to bombard cancer cells and kill cancer cells. So this is a typical linear accelerator. Doesn't look anything different than any other linear accelerator that anyone would have installed, except there's a lot of AI and there's a lot of technology built into this linear accelerator here. So what generally happens with patients that need radiation therapy is they have 20 times they have to visit the hospital because they need 20 sequences. So they leave home, go to the center, get scanned, go back home. If you've been through it, you know. The AI technology allows us to reduce that by half. So they only have to go to the hospital 10 times for these treatments. That's massive. The stress it takes away from the patient, all the good things about this are just massive. But what's it mean for design? If we look at the way we normally design a bunker, and we call them bunkers because they're bomb-proof, we have two linear accelerators. They both have their own service contracts. We got big, huge, thick walls, a lot of cement. We're talking about carbon footprint, all of those things. Well, if we can do twice the patients on one now, we only need one bunker. We literally just saved at least 80 tons of floor loading. That's what I've sort of calculated in my head, so it'll be recorded, so don't quote me on that, even though you can. But we also, the spatial requirements, we don't have to clean that space anymore. We don't need we don't need 2 service contracts. We don't need the air conditioning. We don't need all of those things that you need for that space, so we can repurpose that. So there's one project right now that, again, nice and early, they asked me, and I was able to give them this advice, and the first thing the project director said was, oh, we can keep the parking lot. They were concerned because there were really space constraints. So how cool is that, right? Besides everything else. And of course, the whole of life cost, and obviously it's a positive impact on sustainability. Digital operating theaters. Now we're moving into theaters, right? So digital operating theaters, what's DOR? DOR simply means anything that we can image, we can capture digitally. So you've got, in your pendants, you got cameras. Around the ceiling, you got cameras that actually record what's going on. You got instruments, you got ultrasounds, you got scopes. All the statistics, we can capture all that digitally. And what's cool about that is once it's captured, we can share it anywhere we want. Now, obviously, there's security around that and everything, but we can share it. Anyone can see this now. The other thing we can do is we can record it and look at it later and second-guess ourselves, which is great for the, I guess, people with OCD. But the other thing is we can use Teams the same way we had Teams on earlier today. People on Teams can dial in and actually see everything the surgeon says, the surgeon sees. So, why is that important? Well, let's have a look. So, PETA will tell you it's important. So PETA from Gosford, I had a chat with her. She has an affiliation with the University of Newcastle and with the medical school there. So what PETA does is, instead of having 2 or 3 lucky students that used to go to theaters, get gowned up, got the infection control issues, we're all architects, we know all these dramas with that. You get 2 or 3 students that could go watch 1 or 2 cases, and that's it. We can now have 50 students dialed in. They can see multiple cases over and over. They can see multiple doctors doing multiple cases. So when they come out of university, they are so much more informed than the students 10 years ago. This is just awesome. What's this do for our workforce? Just think about it. Well, there's a couple things that are happening. One of the things that's happening is the students they've embraced this technology already, so when they get out, they're expecting it. The other thing is they also know that they can talk to each other, because that's what kids do now. They're all on Instagram and everything else. So when they go their separate ways, if they need a second opinion, they just call their mate, and they can do it now if we can enable that. And this is where I'm going with this. How do we enable that? And this is what we want to get to today. What else can we do? So Cassandra, Campbelltown Hospital. Beautiful setup they have there. They're also involved with university students and all that other stuff. About every 3 months, they have complicated spaces, and they set up a call to where all these different people can dial into the call and watch. So not just students, but also some of the more experienced doctors as well. What I thought was interesting is there's 2 takeaways when I spoke to Cassandra. She's really excited. She's got a great program. But what I thought was really exciting was one very experienced surgeon had a couple approaches he could take. He was just going to remove something inside somebody. And while he was there, he's got his Madonna mic on, and he's talking to all these experienced doctors. So he may have 30 years of experience, and he has probably a really good approach. However, he's got the capability now of getting all of these other opinions from these senior doctors. So what he did is he consulted the rest of the senior doctors. So maybe he's got 200 years worth of surgical experience on the phone, and he used a different approach. So he had a consensus approach. How cool is that? The other thing is I learned a new word, buddy surgery, and I'm hoping it sticks because Cassandra told me about buddy surgery. What's buddy surgery? There was a regional patient that was too sick to travel, too unwell. The surgeon out in that space was not confident enough or didn't have the experience enough to do whatever the complex surgery was. They set up the DOR in Campbelltown to enable them to be in the room at this regional site. They had it all set up, they tested it, they were all ready to go. So that doctor that was going to perform the surgery in the regional site now had all of this experience right next to him. How cool is that? Unfortunately, as the patient was going through the anesthetic bay, they started to deteriorate. So it never happened. But I still see it as a great success because, one, the intent was there and the trust was there. This is awesome. How do we take this to our regional sites? We got workforce shortages. We know we got workforce shortages. We got talent shortages. The whole theme around here has been revolving around that. How do we do that? Well, let's just push the envelope a little bit. So the guy on the right is in Nebraska. He's operating a surgical robot. Isn't that cool? The girl on the left is at the International Space Center, at the space station, International Space Station up in space. That robot's working. They simulated surgery in space. A guy in Nebraska. Okay, I'm from America. Nebraska, most of you guys probably never heard of Nebraska, but he's doing surgery at the International Space Center. How cool is that? That tells us that for us to go from here to a regional center, how easy is that going to be if we enable that to happen? So what's this do for the design? Am I over? Oh, crap. Okay. What it does for design, design's easy. Sorry, I'm looking this way. All right, here we go. Design's easy. This is where I wanted to get to. It's the change management. We can put DOR in, not a problem. We know how to do it. We got the IT infrastructure. What we have to do to theaters is nothing. It's all in all, it's HFG anyway. That's a great thing, right? We don't have to think about it. What is hard is the new ways of thinking. We build projects in silos, and we don't think, I also need to sort of engage these regional hospitals, or how do we enable that talent? And now it's the Q&A section that I just ran 5 minutes into. So my question to you guys is, how do we do it? We got all these people in the room, so I'd like to hear from you. Twist that.